Hi, I'm Erica Berry, Injectorbunny, and we're gonna do something really fun today. This is,
Justin Cohen, facial plastic surgeon. Hello.
and we're teaming up today.
I'm crashing, honestly.
I'm kind of crashing, but
I'm crashing. I'm taking over.
We want to bring it together to really do a couple of fun things. But the number one thing I'm always interested in is, what is your biggest pet peeves with injectors?
Yeah. So
Be nice.
Well, I mean, I can be as mean as you want me to be. My biggest pet peeve, honestly, is that a lot of them forget that what you are doing can go horribly wrong.
Yeah.
And there's a lot to know in this. It's basically you're practicing medicine, and we need to remember that these are patients. These are not just clients buying a purse.
Yep.
And shit can go wrong, and when it does, it goes horribly wrong.
Yep.
So you go and do like a weekend course, and you're this master injector expert, and all of a sudden you can just see and do everything and treat everything.
Yeah.
And that's not appropriate. So I think just it's helpful to understand limitations, understand what it is that you don't know. Because if you don't, I think it's dangerous.
Yeah, and I think the most experienced injectors are the ones that say no. Like when I first started, I learned how to do everything and I was saying yes and doing crazy things. The more experienced I became, the less I do and the more I refer out. So I think it's really important to know, I always say the three things. Number one, the fixer surgery. Two is the non-surgical, I'm improving, I'm preventing. And number three is no treatment at all. It's totally okay to do 1 and 3, even if you're a number 2. I'm a number 2, that's what I do, is non-surgical. But I always say, if you want this fixed, if you wanna lift, if you wanna tighten, the only thing that lifts your face is a facelift. That is it. So I think it's really important. Yeah, scene, the end, period, that's it. Filler fills, which indirectly sometimes gives support, but it does not lift your face, does not lift your gels. So important to have referral-based system. The DMV, we're so lucky to have so many amazing physicians and board certified plastic surgeons, but you have to know who to trust and who to send your patients to.
And speaking of plastic surgeons, what are your biggest pet peeves of my side of the world?
Okay, so definitely Patreon peeps, I hear this all the time. In the DMV, we're very lucky. I don't have this issue. I think sometimes, just sometimes, not you.
I have thick skin,
not
you can be honest.
But I think sometimes egos get in the way and saying like, well, I'm board certified plastic surgeon, I'm a physician, I know X, Y, and Z. And again, this doesn't happen in the DMV, but I think it's really important that we all collaborate together.
Okay, we're done here, thank you.
We all collaborate together and work together, but I think sometimes ego gets in the way. Hell, it happens to me, ego gets in the way. So I think really putting your ego aside and working together and realizing and I always say to anyone, what's your goal? Do you want to do surgery all day, or do you want to inject all day? Do you want to do a mixture of both? But figure out what your niche is and then refer out, which I think is important.
Yeah, it's perfect. I mean, I do not want to spend my time and my days doing things I don't want to do.
Yeah.
Right? And I've been very lucky and blessed, and I've focused my practice to really specialize in surgical facial rejuvenation.
Yeah.
And I don't want to do anything else, but there's a lot that I can't treat with that alone.
Yep.
Right? So I want to have this network of people and practices like you and like this place that can really be supportive in every way possible, so that I can do a facelift and a patient can still go and get further tweaks and refinements and make things as good as they possibly could be.
Yeah.
Because surgery can't fix everything.
I love that. And even when you get plastic surgery or a deep plane facelift and neck lift, you still need skincare.
Yes.
Retinols, maybe a laser cool peel, maybe a little bit of lip filler, but you always want to do minimal tweakments. I say for the first year after any major surgery in your face, I don't touch them with a 10-foot pole until I get clearance from their actual physician that touched their face. So
what about a 10-foot needle?
Yeah, could you imagine the corner? But I think that's important because people will see a patient and, oh, I had work done in Iran or in Korea or somewhere, but I say, I need to know from your physician when they want you to restart Botox, and you'll use a lot less. And that's another thing people don't know. You gotta then change your protocols, change your treatments. You can't just blast them full of neurotoxin because that's gonna really, cause issues.
Correct, yeah.
Yeah.
It's just, the other thing is timing of non-surgical stuff around surgery, right? Either before or after.
Yes.
How long are you waiting after? Is it 1 year no matter what after surgery?
No. Well, I'll just take you through the whole thing. So first thing is, if they're coming to see me as a brand new patient and they're a blank canvas, I've never touched them before, I say, if you're interested in surgical treatments, anything, you need to see Dr. Cohen first. get that assessment first. Then if you decide to put off surgery for a couple of years or a year, then I want him to tell me, or you to tell me, then, okay, we're not gonna do the deep plane facelift for another 2 years. We're gonna go ahead and proceed with neurotoxin, other modalities, and
Which
then,
I do a lot.
Yeah.
I'll see people and I'll be like, you're not ready.
Yeah,
We need to go back. Here's your plan. I'll see you soon.
exactly.
This is what you have coming up, but you're not ready now.
Exactly.
Which I think is important.
And then after, you have to wait for the actual provider to say, okay, yes, I'm okay with my patient having neurotoxin, what do you like, 12 weeks after? What's your normal time?
So
after?
it varies.
Okay.
And to be honest, like people I think kind of overthink it in some ways. If you have true gravitational change, like your soft tissues are actually lax and gravity's winning, there's no amount of Botox or even filler that's really going to make that, like, I can't see that. I can't diagnose that, right? So if you like had filler done 6 months ago, or you had Botox 2 months ago, and you're like, oh, well, I have a consult coming up with Dr. Cohen, what am I gonna do? He's not gonna be able to fit. Don't worry, like, it's fine. It's not the end of the world. We can see it. But in an ideal world, everything's kind of worn off. Botox, at least you're 2 months out from a treatment. In an ideal world, 2-3 months. We wanna get you back down to baseline as much as possible, and then we can truly assess and move forward with the treatment. The other thing is, if you're getting a lift or you're getting some type of surgery, why the fuck are you going in and getting Botox and filler right before it? Like, you're just going to be healing and you're swollen. You're not going to go outside and you're just wasting your money and your time, and it may actually affect the surgical result at that point too. So I think both of those things are important.
Yeah, and where I started was in plastics, and my boss has always said, it's like taking your money and lighting it on fire, number one. And number two, it does really affect the healing process and swelling. And when you're taking neurotoxin, it's essentially paralyzing the muscle. Those muscles are sometimes very important in healing. So you want everything to be as perfect as possible and no risk of infection prior to the surgical procedure.
Ironically though, there are actually some surgeries where we'll intentionally add Botox right before. For example, a brow procedure or an upper eyelid, sometimes we want the muscles to be relaxed so that they're not pulling on the repair, and it just gives a better result overall. So that's something, little tweaks. But timing like that it's important. So important. Yeah. So we're talking about Sculptra.
Biostimulants.
Biostimulants. So, well, biostimulants is not just Sculptra.
Okay,
right?
let's just talk just Sculptra.
Sculptra in general. So I think that when Sculptra first came out, it was a godsend for HIV patients and lipodystrophy, right? So people who have massive fat loss throughout the face. So traditionally we're talking about true like facial wasting, where you've lost volume throughout the central midface, throughout the lateral face, and in the temples. Those two areas, in my opinion, are still perfect for Sculptra. I think it's a great way to add global volume throughout the midface and into the temple. I think it's great. The problem is, I think that the benefits from those two areas have been extrapolated into the rest of the face. And the way Sculptra works, in my opinion, I don't think it's ideal for those other locations. And that's where I think the problems happen. So as a facelift surgeon who's coming in to the face regularly and seeing the consequences of a Sculptra treatment. So just in case you don't know, Sculptra stimulates a reaction in the face. It's called fibroplasia, which is basically the introduction of granulation tissue and scar. So it's cute, and we can talk about it making collagen and stimulating stuff, but the reality is that collagen is scar collagen. So in many areas of the face, that's great. We just need volume. But in areas where you have thinner tissues or areas of the face that are very reactive, they're more prone to things like nodules.
So give examples of areas.
So under the eyes, big no-no, or very, very superficially anywhere. So again, as a facelift surgeon coming in and I'm doing a deep plane facelift, if I'm seeing scar, and it's like cutting through concrete sometimes in these faces where that scar has just been at work for so long in a place where it's not ideal, it creates problems. And there's many, like it becomes very controversial because there are some surgeons that are like, oh, Sculptra's the fucking worst. Like no one should put it anywhere. And the injector is like, well, I can't do a facelift. I want to help them. I can't do fat grafting. This is a great option, right? And that's great. But I think there's a happy middle ground here where if we understand where it can be done safely and appropriately and really, really beautifully, I think that's awesome. Why wouldn't we want that, right? And accepting that there are limitations and knowing how it works, I think injectors can use it really well, and it can look great and not have as many complications, and I think it can get a bad rap. But that means placing it not directly under the skin, coming a little bit deeper, or placing it in areas where it's not super thin skin, and you just know you're going to have problems. I think if you focus on primarily lower kind of submalar area or temples, you can get a great, beautiful result.
Agreed.
If you're looking for volume in other places of the face, I think fat grafting is usually ideal.
Yeah.
Or obviously there's dermal fillers, and then within fillers, there's some that are better than other areas, and obviously, I don't know as much about that as you do. Yeah. So I think it's a conversation that requires multiple different opinions. There's no right answer here, but I think if we accept that some things are better than others and we understand how Sculptra works, then it can be used really well.
Yeah, and I think everybody's different. So for me, I'm a big believer, I don't use it to grow collagen. So the way it's dosed is normally like 2 vials every 6 to 8 weeks. Times 3, to me, that's an obscene amount of PLA, and I don't do it that way. If anything, I'll use it in the same area. Temple, which requires a lot of volume replacement, and if they don't want fat grafting, preauricular, very, very lateral, where I'm very hesitant to use it around the mouth at all, or eyes, because you think about those muscles, right? Your sphincter muscles, or orbicularis oculi, or orbicularis oris.
Stay away from areas that move a lot.
Yeah, and when you are more mature, your skin is so thin, so it doesn't handle anything well. It doesn't even handle hyaluronic acid very well. So I think it's really important to think about your actual pathophysiology of aging and what's happening. If you are aging with that bone loss, skin loss, collagen loss, consider doing other modalities surgical first. If not surgical, then other modalities like a skin, Morpheus, CO2 ablation, cool peel, all those things, and then consider do your dermal fillers or biosimilars.
Love it.
Yeah. So we're gonna talk about upper blephs, when to use them, when to not, when to get them, when to refer out. I think in general, with a very mature patient, that their skin, again, is too thin. And if you think about neurotoxin, how you're using a neurotoxin, they think you're gonna get a brow lift or reduction of that fatty upper eyelid. You know, if you reduce the muscle contraction, you're gonna have other issues like swelling, fat hypertrophy. You're not gonna get a brow lift because remember, aging is the bone loss, and that frontalis is very, very thin. So you're not gonna get any lift whatsoever. That's when you really wanna refer out for an upper bleph. Even anatomically at a young age, if you think about ethnicities, you have to consider surgical options, but Dr. Cohen was just enlightening me about sometimes we're doing them too often and too young and too aggressively. So what's your take?
Yeah, so my take on eyelid surgery for a young patient, because you guys are, I feel so blessed, you're sending me patients all the time, and I turn the majority of them away, right? And the reason for that is because I have a very specific opinion as to what surgery for the upper eyelid should entail. In my mind, the whole brand of the Cohen Clinic is that I want someone to be supernatural looking. I will not compromise on that. So when we think about the upper eyelid's composed of multiple different three-dimensional structures. So you've got all this beautiful fat of kind of the under the brow and the upper eyelid, you have the skin component itself, and there's all the muscular functional part of the upper eyelid. So those play together in a three-dimensional way that I think is underappreciated. So with the aging of the eye, you have the fat changes that can go on. Usually there's something called fat loss that creates an A-frame deformity. And so basically when you have loss of fat in kind of the central area of the eyelid, where it looks like the upper eyelid volume has kind of settled in a little bit there. Super common. And then you've got skin excess, where you've got true kind of hanging over and hooding of the skin of the upper eyelid. Those are two clear, very easily fixable things that I think are slam dunks. Yeah. The problem comes when you have a young person who has beautiful volume throughout the upper eyelid because they were born that way. That's their natural eye shape. They don't have a lot of hooding in the upper eyelid, and their eye's working well. So they don't have ptosis, which means the eyelid's kind of like drooping down a little bit. Functionally, they're great. They just wish that they had a little bit more of a wide eye, right? Or like a little bit more eyelid showing. So if they do surgery, and if I remove skin and I sculpt away some of that beautiful volume, ironically, they will look older. And this is not talked about enough. If you look at all these traditional upper eyelid surgeries from like the 1980s, where they really cleaned out upper eyelids, and sculpted out fat and took muscle, and all of those patients are now coming back for fat grafting because they look skeletonized, right? So it's my job, if I'm looking for a natural result, to say, look, this is not something you're gonna like, maybe even immediately, but especially not years from now, because it's going to make you look older. So what I look for is more about highlights and shadows. So when I look at the eye, if you look at highlights and shadows, so I want to see a beautiful highlight of that subbrow fat and that good volume, and I want to see it paralleling the shadows of the crease and the lashes. So if those are all playing nicely together and you have this beautiful crescent that really all those structures parallel across the eye, regardless of how much eyelid is showing or how much fullness you have there, it looks beautiful.
Yeah.
Look at magazines. Like you pull out any magazine, all of these eyes, these youthful eyes, have volume up here. So a puffy sub brow is not an it's not an aging,
Yeah.
it doesn't make you look old. It just makes you look appropriate and natural. And if we sculpt that away, I think they're going to look older.
Yeah.
So I personally, I look for those parallel lines in the upper eyelid. And if you have that already, enjoy it. Like, we don't need to be changing your eye shape just because you want to fucking spend money. And that's not how this works. So I think that a young person who has a good eye shape and doesn't have any functional problems, unless you have true skin, like genetic skin excess, just wait a while. And then at some point, maybe it's relevant, maybe it becomes an option.
Yeah, and I recently learned this, but when you look at a patient straight on or anybody, if you don't see their full eyebrow and that eyebrow actually drops off, then consider Sculptra in the temple, dermal filler in the temple, some cannula, but that is aging, is when you can't see the full eyebrow and people think they need a bleph.
Yeah.
I'm like, no, you just need volume replacement here. And then if it's severe.
Can you see my full brow? Now you've got me all self-conscious.
No, you can't, you're perfect. But then when it's severe and it's hanging down, that's when, to me, not even upper bleph, and I refer to you obviously, but then you're thinking about surgical brow lift or facelifts. If it's like falling in their eyebrows, that's when you're saying no, it's a filler.
Global laxity, global facial laxity. And you're doing that to stay balanced.
Yeah.
And that just goes back to a natural result. You're not going to do just a facelift if their brow's hanging down. Like, that doesn't make sense.
Exactly.
Yeah. So when it comes to Daxify or any treatment really that promises a long-term result, right? So as someone who's not an early adopter, I get super nervous whenever things come out. So I'm like the last person ever to try anything new.
Yeah.
At the same time, my practice is hyper-focused on what I do. And the worst possible thing that can happen to me is someone's upset, right? So I do Botox and Dysport, and I do neurotoxin treatments occasionally, and they're fine, right? Like, but what if they're not? Like, it happens, I'm not perfect, I'm not God, right? Like, if I have a weird result or something, fine. Within a few weeks, for the most part, that's gonna settle out and we move on with our lives, right? But if you have a treatment that's designed to work for 6 months or longer, and they have a ptosis or something goes wrong, what can I do? Like, it's just longer to wait it out. So from my perspective, my whole practice is avoiding problems and simplifying the experience as much as possible. It just doesn't work for my model. Yeah. I think it's great, and I think ultimately it can do wonderful things for a lot of people. And if you don't have to have injections as frequently, that's a great thing.
Yeah.
But I would defer to people who are better at it than me.
Love it.
Like,
love your honesty, yeah. I love me some Daxify, some high dose Juvo. Just kidding. I think you're right. If you don't, and that's the biggest problem I think with what's going on right now with Daxify. People are scared to use it. They don't know how to dose it, and it is dosed inappropriately and blowing people's frontaluses. But if you're trained properly and you know what to do, and like everyone has their specific niche of neurotoxin, I say, if you're trained, go for it. Just
but it comes to like knowing your lane.
Yeah.
And staying in your lane.
Yeah.
I like to drive in my lane.
Same.
I drive really fast.
No, not me. I'm a slow driver. I'm a grandma driver. I don't do all night. I just like to stay in my lane.
But I'm not whirling over here and whirling over here. I know what I'm doing. I'm doing it very well. Yeah. But like, if you want to get off the expressway here, I'll let Erica Barry do it. Like, I don't need to be driving all over the highway. I'm just not having an accident.
But can I just say that's what aesthetics, I wish I could put that on a tattoo on my face. Like, that is aesthetics in a nutshell. Like, stay in your lane. And if you want to change lanes, but put your turn signal on.
Right.
Wait for someone to let you in, and then at an appropriate time, then come into the other lane.
Right. That's a perfect analogy.
Yeah.
Yeah. I'm going to go do a training course. I'm going to put my blinker on. I'm going to train on Daxify.
Yes.
I'm going to be coming over here in a couple months. I'm going to get very comfortable with it. And then I'm going to drive into this lane for a while.
I think it's great. But people want to be in every lane, and I'm just like, pick a lane. Stay in it. Okay, so what are your thoughts on Kybella, and what are your thoughts about PCDC, which is the compounded form of deoxycholic acid? So I am very pro these, so I'm not poo-pooing them at all, but A lot of times people have submental fat that is not just superficial fat, it's actually deep fat.
Correct.
Below the muscle, and anatomically they've got a lot of other things going on. So us shoving a bunch of deoxycholic acid in that area is not only dangerous, but it's not gonna actually do anything for the chief complaint of submental fullness. Therefore, I'm usually referring them because now with anatomy and technology and the way that things are set up, it's actually probably cost efficient and cost effective to do submental liposuction.
Correct.
It's very safe.
So and I will take that one step further and tell you that in most patients who have submental fullness, even submental liposuction is not appropriate for them.
Yeah.
And let me explain. So the neck has so many layers to it. The actual target of either Kybella or liposuction is the superficial fat that lives right under the skin. So that is like, in most patients, 5, maybe 10% of the actual volume in the neck. Yeah. So if you want a 10% improvement in your neck and you want the risk of scarring under the skin or the risk of nerve injury from some inflammatory Kybella reaction, which can definitely happen.
Or you can hit the marginal nerve.
Right, that's what I'm talking about. Like, there's a lot of important anatomy that lives under the muscle here. That doesn't make sense to just blindly dump an acid in there and pray that it hits the fat that you don't like and doesn't hit the stuff that you want. Fat. Right, like go do your thing. That's ridiculous. Yeah. So when we talk about contouring under the neck, you have to appreciate the layers. And if we go under this platysma muscle, you fall into this huge like pocket of bulk that is so many different things. There's deeper fat, there's deeper muscles, there's salivary glands that often grow and enlarge or become ptotic over time. That means they hang down. So if you're not addressing those deeper components, there's no possible way that you can get any true contour. So even submental liposuction, I'm actually talking a lot of people out of because they need deeper sculpting, which requires a surgical procedure where you put a small incision under the chin, which hides super well. But now I have the ability to actually come under and sculpt away and create amazingly crisp definition that oftentimes that patient has never had in their life. Right? Like this is genetic volume that they've been born with. They have an oblique neck fullness that they've, even when they were 15,
well,
they
why
didn't have
15?
A lot of neck.
Because I think patients don't understand why. Well, at 15, I didn't even love my profile. Why did they not have that, sculpted
Because
zone?
their genes are such that they were put together with deeper volume. And that's usually volume that does not respond to weight change. So even if they lost a ton of weight, they probably wouldn't see a lot of contour under there. And unfortunately, the only fix for that is surgery. You have to go in and sculpt it out. Otherwise, whether you're using an acid or a little bit of liposuction, they're just gonna be disappointed.
I love that. So if you wanna know more and you wanna see Dr. Justin Cohen as a patient, you can head over to his page at
Dr. Justin Cohen. Super easy, it's my name. Not very creative.
Love it. That's like the number one thing in social media is make sure your Instagram handle is easy to spell and easy to spot. And then if you want to see me as a patient, well, I'm not taking new patients, but you can see any of the providers at
You can come beg. You can crash your place and be like, Erica, please God, see me.
But honestly, all the providers
Cohen said he can't help me.
You can see Christina, Honey, Melissa, Annie, Sheila, Kelly, Allie, Darlene, everyone here, but go to mokshaesthetics.com.
And at my practice, you can see me, or you can see me, or sometimes, if you're very lucky, you can see me too.
I love it. You can only see me.